Ladies and gentlemen, thank you for standing by. Welcome to the Future of STD Prevention webinar. During the presentation, all participants will be in a listen-only mode. If you'd like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. All questions will be answered at the end of the presentation. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Tuesday, June 28, 2011. I would now like to turn the conference over to Dr. Gail Boland, CDC Director of the Division of STD Prevention. Please go ahead.
Thank you very much, and good afternoon and good morning to some of you. I appreciate everyone taking the time today to have and I'd like to call this a discussion of the future of STD prevention. This is something that I've been having many discussions back here with staff in the division since I arrived about 5 months ago, and have begun having some discussions with the NCSD board, and now I'd like to include interested program directors, managers, and other staff in how we need to be thinking about the future of STD prevention. I think we are at some crossroads. So before I get started, and I do really want this to be, it's hard with our travel budget these days to get together and have meetings, so we want this to be as interactive as possible. As it was mentioned, please type in questions as I'm speaking. Any question is fine. I will only be answering the questions through the chat page today. And certainly this is, I think, a discussion that will continue on for months and the next couple of years. So before we get started, I would like to poll you guys just to see who's out there that has registered. We've got quite a number of almost 300 people participating in the call, at least by registration, and we know sometimes there's multiple people in rooms. So could you start polling in for me as to whether or not you're an STD program director, program manager, frontline supervisor, DIS, epidemiologist, health education specialist, clinician, other public health professional, and other. I guess you'll be a little bit challenged if you've got multiple people in the room that have multiple backgrounds. I actually don't know if you can choose more than one. I'm not sure. If you can only answer a little circle here and have multiple people in the room, just take a vote and decide how you want to represent yourself on our poll. So we still have a number of people logging in. I'll probably just wait till we get to maybe 175 is good enough, and just see sort of the distribution of our staff participating today. So interestingly, we obviously didn't do a very good job with our categories because the majority of responses fall into other public health professional. We do have a number of STD program managers. If we lump them together, there's about 30% are in a position of managing or directing. And then we've got some epidemiologists and DIS and a wide distribution, and even some clinicians. So thank you for that. And we also, I think, have a list of everyone who at least has registered so that if there's additional information we need to get out, we know how to reach you. It's also been mentioned that this webinar will be recorded for colleagues who have interest in the topic, but were not available today for our webinar. So what I would like to discuss, and I'm hoping to do this in about 45 minutes, and then we'll have about 45 minutes for question and answers, is first of all just review the current STD prevention budget for the year 2011, just so that you know how our money is being appropriated and spent sort of from a programmatic perspective. This is something new that we're going to be doing at CDC, making sure that our partners and staff know how our funds are being distributed. I'd like to also review sort of our current approaches to STD prevention, at least from my perspective of what I think we've been doing for a number of years. Next, I'll discuss why we need to sort of rethink our STD prevention services in this era of healthcare system changes. And in that rethinking, I think we'll be discussing sort of our future direction. that I'm interested in hearing people's comments on. Because of where we are and a lot of changes that are going on in the field of STD prevention, I want to at least present to you sort of how I have realigned the division that I think will best meet the needs of the future. And then I want to at least share some proposed vision and strategic priorities, at least on the national level, and the rationale, and would love your input in this area as well for the next 2 or 3 years. So the next slide is showing you our fiscal year 11 appropriations from Congress. This is after, the budget cuts. We were lucky this year that the STD division, and we thank our partners and others, that we were one of the few divisions that were not cut at CDC. So our overall appropriation is $154 million and a little bit of change. So what you're looking at here is that 60% of the appropriation is actually going out to state and local health departments. Now, what I'm counting in this part of the pie chart is funding for CSPS, IPP, and syphilis elimination. I did not include just dollars, our gonococcal isolate surveillance project, because I put that under state surveillance activities. 11% of our appropriations is supporting the salaries of our public health advisor field staff that are supporting state and local programs. 3% of our appropriations fund our prevention training centers, the Part 1, which are the clinical training centers, the Part 2s, which we actually don't support. Those are all funded with HIV dollars. And the Part 3s, which support partner services training and program management training, which is also supplemented with HIV dollars. I guess I should add that in addition to the $154 million, we get an additional $10 million from DHAP. Maybe it's about $11 million now from DHAP to support HIV prevention work. And when we start talking about sort of some of our metrics, DHAP is very interested in knowing now the number of new HIV positive infections we identify through the work that we do with these $11 million. So that's something certainly we're going to make sure that we are reporting to DHAP so that those funds continue. But I've not included the DHAP spending in this pie chart. It's just our STD appropriations. We have a few demonstration projects. I think the CARS grant, the Community Approaches to STD Interventions or Prevention, is one of our new demonstration projects. So only 1% of our investment is really going into some innovative demonstration work. Another 1% goes into what I call state surveillance activities. That's the GIS and the SUN activities that we support. I know some people in their programs in CSPS, IPP, and syphilis elimination invest quite heavily in surveillance activities, and other programs may not invest as much. So I've decided to leave the programmatic pot separately. We fund about 3% in terms of partnerships. These are funds that go to partners like NCSD, the National Chlamydia Coalition. We will soon be funding a sexual health coalition with matching funds from DHAP and the center. So that's where 3% of our budget goes. Unfortunately, if you notice, with the way the monies came out, 0% of our dollars go into research and evaluation. And for anybody that thinks about program evaluation and the need to be science-based, that size of our pie is very small. Actually, we do have some research activities and evaluation activities, and it's $700,000, and that's why it shows up as 0%. So it's actually point something percent. 4% of our dollars goes to what I call CDC support. That's actually monies that is sort of like our CDC TAP. HSS has a certain amount of money that they tap from our appropriation. The Office of the Director has a TAP, and our center has a TAP. I think this is pretty common in many government agencies. We all are tapped by our bosses from above so that they can make sure they have the infrastructure to do the work that they do. And actually 4% is not a high amount of, quote, indirect costs, but I just wanted to have people realize that not all this money is coming to us at headquarters. So that remains 17% of appropriation is covering headquarters staff here in Atlanta and our operations, which includes the usual supplies, et cetera, travel. So this is how we are currently spending our money, and I think our pie chart for next year will probably look pretty similar. So in terms of how I think we currently are approaching STD prevention and the services that we deliver, I actually would like to remind everyone, if you haven't read, and some of you who have been in the field for many years I think have read, but it's pretty interesting to go back and read The Shadow on the Land, written by the Surgeon General Thomas Perrin back in the 50s when the federal government decided it was going to do something about syphilis. And we actually look at the functions of what he said we need to do to reduce syphilis in this country. It's pretty much the same functions that we've been doing till today. I mean, we basically want to have a level of health education, health promotion, and behavior change to prevent people from becoming infected to begin with. He probably didn't have vaccination on his list at that time, but I do just want to remind people that we do have at least 2 vaccines, hepatitis B and HPV, that can prevent some of our sexually transmitted infections. I would say that the bulk of our resources have been used over the years to identify and treat infected individuals. And there's been sort of 3 approaches that we've used to identify and treat in a timely fashion infected individuals. One is we've developed screening programs, and when I use the term screening, I mean that we test individuals to identify asymptomatic infection. And once we've tested them and identified if they're infected, we need to make sure that they're linked to care. We originally designed having categorical STD clinics to sort of be a service entry point for those with symptomatic STDs who could come in quickly and get drop-in, free, same-day care for our symptomatic STDs, although we know that those services have been broadened over the years in terms of what STD specialty clinics offer. And then we've had our health department DIS staff that were responsible for contact tracing activities, which we now refer to as partner notification and treatment. And if you notice, these services are pretty individually based types of interventions. These services predominantly have been funded by, I would call, taxpayer dollars, the public sector. We in the federal government, as those of you working in program know, we do not give you monies to provide clinical services. Those are monies that have traditionally come out of state and local funding sources. And our focus for many years was really on the STD clinic and the work that DIS did. I think a lot of programs have moved beyond that and have broadened both their clinical services and the way they do clinical services and the role of DIS. But I think that has been a tradition for many years. And more recently, because of funding, I think our focus has really been on the infertility prevention activities and the syphilis elimination activities, and then certainly other base activities and core functions that programs determined were important. They would use their CSPS funding for that. So getting to why do we need to start rethinking what are we doing in STD prevention? I think sometimes budget cuts, no matter how painful they are, really cause us to reflect and to be critical and to look at what we've been doing and make sure that we preserve what we're doing well, but also recognizing some things that we were doing in the past which were really good and were really needed 10 years ago may not be needed now. And we really need to be honest about, what are our current needs, what are our current priorities given the resources that we have. So the rationale for sort of rethinking STD prevention services, and I'm just outlining, some of my thinking here, and I do feel that we're very much in a survival mode. I think, we're hearing across the country, and some of you, well know, STD clinics are closing left and right. We've got major programs like the state of New Hampshire that just completely eliminated their entire STD budget. So I think that we've really got to be on the front end of this curve to make sure that people know the important services that we offer and the important expertise that we have, and that we're part of this transformation that's occurring and not let it happen to us. So I think the rationale as to why I think we, at least at the national level and here at CDC, need to be rethinking how we're doing business is, one, it's important for us to start anticipating the changes that we're seeing in the healthcare delivery systems. And I'm going to talk about, sort of some of the opportunities I see that this brings to our field and some of the challenges that we're faced with. I do think that one of the overall opportunities with sort of the changing healthcare delivery system is it really allows us to work strategically with others to really leverage our prevention efforts. The goal here is to have other people do it well, not to do it well ourselves. We also recognize that we've got to rethink what we're doing because the economy is not going to be changing overnight. And as all of you who are out there working at state and local health departments know so well, your infrastructure dollars are being cut left and right, and so that's one problem. And then the second problem is that infectious disease, and I say this broadly, not just STD and HIV, but infectious disease public health, which was really the core in the origin of public health, and CDC was actually started as a malaria station, has now been sort of eclipsed by all the chronic disease interests. And so not only are our dollars being cut, but we're having a lot of competition within our public health programs to maintain the work that we do. So I think the overall message here is that we've got to figure out how we can maximize our efficiencies and certainly communicate these efficiencies to our funders, to our bosses, to the public, so that we can have the most cost-effective, highest impact, and feasible approaches to STD prevention in the future. So these are sort of the metrics that I'm going to be looking at when we're thinking about, things that we want to support from the national level. If it's not cost-effective, if it's not having some kind of impact, and if it's not feasible, it's going to be interesting how that can be justified. I want to hear people's comments on that, but those are the things that I'm going to be looking for in our STD prevention programs. So to summarize sort of the drivers of change, for those of you who may not be as familiar with the Affordable Care Act, and this is something that we want to provide more training to our state and local staff. We are in the planning stages of our national conference, which I'd like to remind everybody is occurring in March of next year in Minneapolis. And our planning committee actually universally, it was a very diverse planning committee. It did not just include STD members. It included people from DHAP and NASDAD and reproductive health and adolescent DASH issues. And overall, everyone said we need to figure out what's happening with the healthcare reform and how we're going to be moving forward in this new changing era. So we're hoping that this conference will be kind of the go-to conference so that people can really figure out the direction and their roles in this new changing environment. So one of the things that the Affordable Care Act does is actually increase access to health insurance and to some prevention services. So if you don't know, clinical preventive services that are recommended by the U.S. Preventive Services Task Force or the ACIP, and there's also going to be some additional recommendations by HRSA. If recommendations are deemed to be A or B recommendations, and currently chlamydia screening for young women and gonorrhea screening for at-risk populations and screening in pregnancy are considered A or B recommendations, these services are going to be required to be provided with no cost sharing for the individual. So this is a huge opportunity for us in the new healthcare delivery system for these prevention services to be offered with no copays and pretty much be universally available without us having to use any of our money from our $154 million appropriation. The other change is that young adults can actually remain on their parents' health plans until the age of 26. It doesn't mean the child or young adult has to live with the parent. They can actually be married and living in a different household. And obviously, since the burden of STDs is predominantly in people less than the age of 26, this is another important coverage or access to health care that I think affects our field. There's also been billions of dollars going into improving the primary care network, the federally qualified health centers, other community health centers, and school-based clinics. So these are very important partners that we need to be working with. because they're going to be a network of primary care providers that are really going to be serving our priority populations at risk for STDs. And if we can get them trained and help them provide quality services, again, this will not be costing us anything out of our STD prevention appropriations. Sorry about that. The other important parts of the Affordable Care Act is that Medicaid is expanding to go up to 133% of the poverty level. For those of you who are not that familiar with the Medicaid program, it predominantly in the past has been serving moms and babies. So the non-pregnant young woman or young men really were not having access to this health insurance program. So there will be more younger non-pregnant women and young men, which are important populations for us, that will have access to Medicaid with this new expansion. And the other area that I've seen in the change of Medicaid is for years, in my experience working with them, they pretty much were worried about fraud. They were worried about, people, milking the government, deep pockets for, their profit. And the good news is, with the interest in cost containment of our healthcare system, recognizing we basically have a system that's too expensive with very poor outcomes, there now is an interest in looking at quality of care in Medicaid. And we at CDC are working closely with HRSA and CMS. So at the federal level, we can help them improve quality of care in the area of STD prevention. But there's huge opportunity also for state and local programs to be working with their state Medicaid programs to ensuring that the quality of care provided through Medicaid and through their federally qualified health centers is the standards that we have come to expect in STD prevention. If you also don't know, there's been huge investments into health information technology in the healthcare delivery system. Federally qualified health centers are now, most of them are moving towards electronic health records. And if by the year 14 they're not using data in their electronic systems, they will not be reimbursed by the federal government. So this is another area where there's huge data systems that are, I potentially think are going to be available to us that will be of benefit to the work that we do both in our surveillance, assessment, and assurance activities that I think we're going to be spending more time on, which I will be discussing. Now, as I mentioned, the other driver of change is we've got the changing healthcare delivery system, but we've got the declining public health infrastructure. And again, this is a survey that I appreciate that NCSD shared with me that was also done with ASHA. And again, I know a lot of times when you guys out there in the field are asked to do surveys, it's like, oh, one more thing, I don't have time. But it is becoming even more critical for us to document. We do surveillance on disease, but we also need to be doing surveillance on infrastructure decline and the impact of these lost services. So we are interested in working with NCSD again on this year to do another survey to really have another point prevalence on current infrastructure issues in STD programs. So at least in 2008, 2009, for those of you who haven't seen these data, they have been presented at the STD conference last year. At least 69% of state or local programs said they had some kind of funding cuts. Now the problem, as you can see with these data, is these percentages don't quantify the funding cuts. Was it a 0.10% of an FTE? So we need to do a better job of quantifying these funding cuts. But we know that initially when funding cuts occurred, 40% were sort of in the disease investigative services area, 37% were laboratory services were cut, 32% had clinical care or screening services cut, and only 5% of states, and these are the percentage of states that reported some kind of cut, reported some kind of cutting of HIV test or hepatitis B vaccination. Now, my interpretation of this result is that, first of all, given that HIV tests, many are funded through HIV prevention programs, which weren't cut. That may be a reason why so few states cut HIV testing. And my other argument with the hepatitis B vaccination is so few states are actually doing hepatitis B vaccination, the bar was pretty low to begin with, so there wasn't much to cut with the programs anyway. We also are monitoring not only service delivery cuts, but what we call infrastructure staff cuts. If you don't have staff, you don't have a program. So those of you who work in local health departments are well aware, and I think CDC is now recognizing these significant challenges at the state and local level, that either your salary is being frozen or your salary is being cut, you're being furloughed and told not to work, and we even are starting to see a significant number of layoffs occurring in state and local health departments, and there was recently just a study put out by NACCHO about the number of positions that have been actually lost at the county level in public health in the last year, and it's quite significant. So with those two drivers of change, be it the opportunities with our healthcare delivery system and the challenges that we're facing with the budget shortfalls that governments are having these days, let me talk a little bit about the opportunities I see and where I see us working in the future with these changes. So first of all, as I mentioned, I think there's huge opportunity to scale up our quality STD prevention services. And we actually have a very good model with one partner we've done this with. I think we recognized a number of years ago that a number of at-risk women for sexually transmitted diseases were seen in family planning clinics. Many family planning clinics were only funded to provide contraceptive services, and thus the creation of the Infertility Prevention Project that really was designed to increase screening for chlamydia and gonorrhea of women in need in the family planning setting. So we need to reflect on that model and really look at how can we take the lessons learned of that model and have STD program directors start working with federally qualified health centers, school-based health centers, other community health centers, so that we can start advancing the quality STD prevention services that we've been able to do in the family planning setting to these other settings. We've also been talking a lot about PICSI and the need to do a better job of service integration at the client level. We're not necessarily talking about programs integrating. Programs do need to collaborate, though, let me remind you. And I think when we start working in new models, and especially when you're working with community-level providers, they're very integrated-oriented. It's like adolescent providers. Adolescent providers don't just want to hear about chlamydia. They want to hear about eating disorders. They want to talk about, bike helmets. They want to talk about bullying. So I think the good news is when we start working in these with these new partners, it's important for us to maintain our PICSI focus and look at making sure that we're providing holistic and comprehensive STI, including HIV, hepatitis B vaccination, et cetera, and sexual health models in what we're doing. The second area I think we've got huge opportunities is with this whole new health information systems. I think these are data systems that we are going to need to learn to have staff better understand the data available, the data that are available, and how to actually analyze some of these data systems, learn how to work with your Medicaid programs and the data they have in your states, and see if you can be looking at chlamydia screening, timeliness of treatment, other things in those systems. Because if you actually look at the healthcare delivery system and people who look at healthcare services, and they actually call themselves health services researchers, and they're developing a lot of quality care measures, a lot of the principles that they are using can be used for us to use as a basis for more population STD prevention measures. And so when I think about these new systems and think about these electronic medical records, what these electronic medical records really allow us is to have a comprehensive longitudinal data system or data set on well-defined patient populations that we really could start looking to use towards improving our surveillance, looking at some different metrics in terms of what we measure as opposed to our notifiable disease system with very limited data. They are also systems that we can use to start looking at assessments of screening rates, of who's treating patients with gonorrhea and syphilis with what drugs, and how timely is the treatment, are partners getting treated. And then once we assess the quality of care, then we can design quality initiatives, implement those, and then look at improvement over time in these settings. So this is something that I think provides huge opportunities to us, and I think we can reach a much larger population than we currently serve when we look at patients coming into our STD specialty clinics. However, I will say the challenges that we need to be clear about and we need to keep an eye on, and we need to educate our bosses and funders, is insurance coverage does not equal access. Just because you have insurance, it doesn't mean you're going to go in and get care. So we need to be monitoring for those that do have coverage. Are they actually accessing care, and are they getting the care that we expect them to get in terms of our definition of quality STD prevention services? Second of all, we recognize that there are generally going to be people that aren't going to access care for a variety of reasons, even if they have health insurance. We know many people come to STD clinics because they want confidential care. They don't want their provider or their parents or their partners or their family to know that they're going in for an STD concern. So I do believe that we still are going to need safety net STD services. We're going to need categorical STD clinics, but we've got to articulate why we need them. We're going to need DIS to do partner services and other activities. This is not something that the general healthcare delivery system has expertise in and knows how to do. And then if you also don't know, we've got a significant number of populations at risk, our probably most vulnerable populations for STDs, such as the incarcerated, and the undocumented individuals that aren't eligible for this new healthcare delivery system. They're not part of the Affordable Care Act. So when you're incarcerated, you're not eligible for the services that are recommended by the U.S. Preventive Services Task Force. If you're an undocumented individual in our country, not only are you not eligible for these services, but these exchanges, there's going to be these health exchanges that people can buy into that don't have health insurance, that are low cost. Undocumented, even if they have money at the moment, are not allowed to buy into any state health insurance exchanges. So this is going to be populations that we're going to need to monitor closely and figure out other innovative ways to make sure that they get the prevention services that they need. So I think that some of the challenges that we're going to be seeing and things that STD programs are going to need to focusing on, I already mentioned that I think STD prevention programs are going to be playing a much more important role in the assessment and the assurance of the coverage and quality of STD prevention services that are provided by these essential community providers, including federally qualified health centers, Medicaid providers, school-based health centers. However, we're going to have to identify what are the barriers when service is not being delivered or the quality of service is not at the level that we expect. And I will say that in areas that have closed STD clinics, we are already starting to see some of the challenges. Certainly when you walk into a primary care clinic, there's not a stat RPR test that's available or even a dark field, although I think there's so few people that know how to do dark field these days, I don't even know if they're available in even some of our specialty clinics. Another area that we're finding difficulty is that when patients need injectable medications like benzathine penicillin and soon to be ceftriaxone is the only drug that I think we're going to be shortly recommending to treat gonorrhea with, those drugs are not on the shelves when the patient comes in with gonorrhea or the contact comes in with syphilis. So how are we going to get timely treatment with injectable medications when the clinic doesn't have them available? I think we know that a lot of our providers are not equipped to deal with partner management. So I think we're going to need to figure out how we can ensure and develop innovative ways that we can assure partners are treated in a timely fashion. And then lastly, as I mentioned, one of the reasons that patients like specialty STD clinics is for the confidential services that are offered. And we also have some challenges for those of you who don't know what EOBs are. That's explanation of benefits. When you work in the healthcare delivery system, you do bill and you need to get reimbursed and you need to be itemizing the services that you offer. So a lot of these bills currently, if an adolescent comes in for care, even though the adolescent is supposed to be afforded confidential services without parents knowing through state minor consent laws, unfortunately, the healthcare delivery system and the insurance systems don't realize that they're actually breaching that confidentiality when they send the explanation of benefit home to the parent, and you can see that the patient received a chlamydia test on that visit to the clinic. So the other challenge I mentioned that we're going to need to be working on is defining our safety net. I think just saying we have a good STD clinic, we need to exist, we provide good services, doesn't carry a lot of weight these days in these challenging fiscal times. So I think that we're going to have better data on what the safety net needs are that are not being served by the healthcare delivery system so that we can justify the need for STD specialty and safety net services. But I think just having data to drive our argument is getting more and more challenging these days. So I also think that specialty services have to start thinking creatively of how are we going to start becoming part of the healthcare delivery system. Certainly, STD clinics are not going to become a medical home because to be a medical home, you have to provide primary care services. But STD specialty clinics can become part of the medical home. There's a lot of referral services that your primary care doctor provides. And so I think we want to look at programs that are having trouble sustaining their STD specialty services, including their DIS, and start finding ways that we can have them become part of the medical home, that are STD expert clinicians that know how to take care of complicated syphilis cases, that they actually become an essential community provider, and that they will bill for their services, that DIS need to be seen as essential community providers, and we can bill for their services. And then lastly, public health, and this is not just unique to STDs. We've been running our little mom-and-pop excellent clinics for many, many years, but we are now behind in terms of technology and electronic health records. And for us to be able to survive in this technological world of the new healthcare delivery system in general, we need to start working and ensuring that our STD clinics are up to speed with technology and have electronic health records. I know some places have started moving towards paperless DIS case management, but I think this is where if we have everything electronic, it's going to be easier for our healthcare service delivery folks to see that we kind of fit into their system, and I think they're more likely to embrace our services, and it will certainly be easier to bill if we are up to speed electronically. The other challenges that we have if we want to start having our surveillance teams work more with these large data systems, clearly we've got challenges because our computers sit in silos and they don't talk to anybody else, and we've got people printing things out and re-entering them into our computers. These things take resources, which we know are challenging, and I am encouraging programs, if they would like to use carry-forward dollars, to improve their IT with other parts of their department. For those of you who use STD-MIS, we are going to roll out STD-MIS 0.5, but that system is a dinosaur and it's on its last legs, and we have no budget, as you saw in my pie chart, for IT support. So we at CDC are going to be getting out of the business of supporting STD surveillance at the state and local level, and staff are going to have to start working with their state and local NEDS-based systems or whatever systems your state is building. And you need to know who your communicable disease people are, because these things are being built as we speak, and are going to need to make sure that STDs are part of your broad-based public health department, electronic, both lab and provider reporting system. I will say some of the challenges of these new data systems is they're big, they're complex, so these are kind of new data systems that we're going to have to learn how to work with. And then to be honest with you, for those states that have been working with some of these data sets, most of these pathways to work with the data sets have been built on handshakes. And now that I think all of public health is going to be looking towards these data sets, it's going to be another situation where we're all going to be lining up to take a number. So I think public health in general is going to have to start defining the roles and responsibilities and the relationships between public health and the healthcare delivery system. And I will say there is an office out of the Office of the Director at CDC that is working on this, and we are working with them closely to make sure that we are not forgotten and are going to be able to have access to these data systems. Our other challenge, I would say, is that with all these changes and all these new things that we're going to need to do, and we have no new money to just hire more new staff to do this, is we're really going to need to realign our staff so we're fit for purpose. So I do think that there's going to be an expanded role for DIS. I mean, a lot of DIS have already expanded to do many different things, but I think the traditional role of DIS of just doing contact tracing is not going to be the only need. I would say, though, that we don't want to lose the field investigation expertise of DIS, because as you know, when there's H1N1 or anything else, there's a problem, and somebody's got to go out and figure it out. Who are the first to be called but our DIS staff? I just want to let you know I am equal opportunity with people that I approach for leveraging resources, and I've mentioned to my colleague Dr. Ken Castro with his unfortunate budget cuts that he's taken, and there's some significant cuts that are occurring in TB, is I have mentioned, well, why don't you just fund, a quarter time of a DIS over in that STD program, see if they can get their staff cross-trained to do TB work. They can be part of the STD team for the day-to-day work when nothing is happening, and then they can be mobilized to help you with TB. So I encourage those of you here working in STD and not in an integrated program to reach out to your TB colleagues, because they are having a lot of cuts, but I think there's some ways that we have a lot of skill sets that are very similar to our TB colleagues. We don't really have overlap in our populations, but I do think we need to start thinking creatively how we can support each other. I also think for programs that don't have a lot of staff experienced in surveillance and epidemiologic analysis, for staff that don't have expertise in quality improvement, who don't have staff expertise in program evaluation and don't have expertise in policy, we want to work with you on developing that expertise. And certainly it's an area that we're going to be looking at providing a lot of training and workforce development, at least for staff that we have in the field, so that they have some broader expertise and can assist in these areas as well that I think are going to be areas of focus. So in summary of the future direction, I can see that I'm talking, as usual, a little longer than I anticipated. I think my comments are prevention through healthcare is coming. A lot of people say, oh, the Supreme Court is going to overrule everything and we're going to be back to square one. Already we're out of square one and we're into square 2 and 3. So I think that we need to take advantage of where we are, stay ahead of the curve. We really need to focus on public and private partnerships. I think we're going to be spending more of our resources on assessment, assurance, and policy development. Programs will be doing more in developing guidelines, tools, training, technical assistance. There's a huge amount of work to be done. So for those of you who are worried, what am I going to be doing? We've got lots of work to be done. I think service delivery is going to be less of a focus, but still we are going to need to have our safety net services. But we're going to have to work on getting them as financed as best as possible. I mentioned health information technology in the healthcare delivery system we need to take advantage of. We need to retrain our staff. And again, we need to take this opportunity to really be more upstream in our interventions, more holistic, and really start looking at these combined intervention approaches we're using and measuring what the overall programmatic impact is. Now, I will say that I think we are challenged by the current prevention program metrics we have. Everybody today, I think at the state, local, and now finally this year at the federal level are being asked, what is my return on the investment? Congress wants to know, I give you this amount of money, I've got my $154 million, they want to know what the return on the investment is. So we're going to be thinking at the national level metrics we need to have to be able to justify to Congress why this federal appropriation needs to stay or, if we identify need, increase. And I think we also want to work with state and local programs so that you have metrics that you can take to your funders, your legislators, and justify why your program should not be cut. Because the question that everyone is asking is, if this program goes away, so what? That's the question we need to be able to answer. Okay. Just to kind of quickly go over how the division is restructuring sort of based on these needs. I'm just going to, and the only reason why I want to let you know the direction we're going in, it's going to take us a few months to get there, just because obviously for partners it's very important so you know who to go to in the division for what. This is a work in progress, so I would like to get some feedback on your needs out in the field so that I can make sure I address those needs in this structural realignment. I have a number of rationales as to why I felt that we needed to realign at the division for me to keep from going crazy. No, only kidding. Is that I really did feel that there's a lot going on, there's a lot of changes, and we really needed to be positioned to be the best as we could be in sort of this changing environment so that we could be more efficient, better focused, have greater impact, and that we are in a position to sort of maximize opportunities of leveraging other resources, and a lot of that opportunity is working with other federal agencies. There also have been some gaps in our structure. We've not had a lot of focus on implementation or translational science. We've not had a lot of resources going into sort of evaluating programs at a level of prevention impact on a population-based level. We've had the flagship guideline that comes out of CDC, the STD treatment guidelines, but given that if we have evidence-based guidelines, and these will be covered with no cost sharing by our patients, we need more evidence-based guidelines. We need guidelines on screening and MSM. We need guidelines on expedited partner therapy so that these services can be seen as quality A or B recommendations. So that's an area where I felt like we had limited resources going into our guideline development and into sort of sharing of best practices, developing tools, toolkits in our sort of quality improvement initiatives. As with any organization, there's always areas of improvement in terms of getting your teams working better together, improving morale and collaboration, and supporting all your staff, and making sure that our field staff feel connected to the division. And then lastly, we all work for our bosses, and so I also wanted to make sure that our division was meeting our agency and center priorities. If you don't know, Dr. Frieden is very interested in modernizing surveillance at the state and local level, and also very interested in making sure that we're supporting state and local public health infrastructure. He has some winnable battles domestically of HIV and teen pregnancy, which we certainly fit into, and a global winnable battle of congenital syphilis elimination. And then we have our center initiatives of PICSI, sexual health, health equity, and social determinants of health, and there is now a new initiative at the center level of prevention through healthcare. So taking all of these goals in mind, the new structure for the division, and again, I was also advised not to just move the deck chairs for moving the deck chairs and to minimize changes unless they were needed. There really is no change at the Office of the Director level. We have an Associate Director for Science. We have a Policy Office of Health Equity, Global International Activities, which I've been told is a priority by the center and something that we have to work on, and a Management Office. The Laboratory Reference and Research branch is the same. The Behavioral Intervention and Research branch is essentially the same as our social sciences. I hear they're coming up with a new title for what they do, because we also have a lot of communication science, health communication science in that branch. And then we're having sort of two branches here that are a little bit different. We're going to have the Epidemiology and Statistical branch together as one branch. And then because of the need to really highlight the important work of surveillance, we're merging our data management, which spends a lot of resources in supporting state and local surveillance programs, which we want to continue to do, and however the new configuration will look, as well as our surveillance team. So that is now a separate branch. Our health services research now has an expanded focus on program evaluation and impact, which is the E. And then the program and training branch is morphing into two different branches. One, there'll be just a separate field services branch to support our field staff, to make sure that our field staff are supporting state and local health departments. And then there's going to be a quality, it's called the PDQ branch, which is quality development and program. The Q is program initiatives. And this is where we'll be having our guidelines unit, our training branch, our program support branch, which is going to be much more of a coordinating role with states in terms of your grants, with a lot of expectations of what the states should be doing, and maybe a little less support from our end, because our resources just don't have the resources to provide as much oversight as we have in the past. And then some sort of special initiatives that will be our strategic priorities. So that leads me to my last two slides. The timelines for this realignment. Some people have some questions. There's a lot to be worked out. We are maybe moving in August, so we're in the process of trying to see if we can implement this realignment sort of by the end of August. But there are a number of issues that still need to be worked out. And this is where I really would appreciate input from people on the field. As we start looking at this future direction, obviously we want to know how is this, affecting people in their day-to-day work, and how does this affect the work that we do with partners. I think we do want to be defining the role of the program consultant. I've actually learned there's all these different terms, the program officer, the public health advisor. What is our role at the federal level for cooperative agreement oversight? I've actually asked PGO that question so that we're very clear what our legal responsibilities are. But I think we all recognize that we all can't be everything to everybody. States need to be responsible for their programs. The CDC needs to be responsible for our national efforts and support to states as best we can. We need to figure out what our role is, at least at the national level, in terms of safety net and field services structure. I'm sure there are other things you need to educate me about. And then obviously, at least at the national level, we've got some gaps in our informatics expertise, program evaluation, and sort of healthcare systems, and some of our legal policy science that we're going to be looking for some positions on. I encourage all of you to look at your structures and identify sort of what your needs are as well, and advocate for those, and we certainly will help support that from the national level. So just quickly to kind of talk about some visioning and strategic priorities that I've been working here on internally and would like people's feedback on. We do have a very robust strategic plan that was created in 2008 that goes to 2013. I think Dr. Fenton feels there's a lot that needs to be done now and does not want to do a lot of long-term strategic planning. We'll use the 2013, 2014 years for that, because that's when a lot's going to be changing. Our CSPS grant's going to be up for renewal, which we want to talk to people about. Obviously, Obamacare changes a lot in the year 2014 in terms of implementation. So I want to kind of focus on where we really need to be focusing our efforts in the short term, and would like feedback from the field, because we've got a couple years here. We need to be discussing this so that we can be moving forward with our new competitive renewal, and certainly need input on the direction we should be going. So just to put a vision statement out here that I quickly created so that people know what we do, and certainly I expect all my staff at the division to be able to, anytime they're on an elevator and have the opportunity to find someone from the Gates Foundation that they're next to, we can say, by the way, have you ever thought about funding X, Y, or Z? Because we in the Division of STD Prevention hope that in the future all Americans, regardless of gender, age, race, ethnicity, sexual orientation, are knowledgeable, empowered, and have ready access to a network of culturally competent, high-quality, evidence-based, and confidential STD prevention services, and a highly trained professionals to prevent, treat, and manage STIs. If you notice there's a little disconnect in my title to the vision statement, I've used the word STD prevention and STI. I am asking everyone for their input. Is it time for us to change our division title to STI? We have an opportunity to do this with Realignment, so I am interested in hearing from individuals in the field. I've gotten some feedback from people so far as to whether or not it's time to move the field to sexually transmitted infection prevention. In terms of how, and there's a little bit of a complicated slide of sort of a strategic map that we need to work on, is first of all, I feel that our core of our program needs to be science and evidence, so that we can justify to our funders, what we're doing, why we're doing it, and why we need to continue to do it. Second of all, if you don't have a public health workforce that's capable of implementing and looking at the evidence and the science, I don't think we're going to get very far. So I think we need to pay attention to our infrastructure, our staffing needs, our staff, because as I've said to my staff here, I think our most important assets are our staff, and at least at CDC, for me in the division, it's my staff and it's our partnerships. Now, we've been looking at some areas of focus, because our current strategic plan has very big picture focus, but not any specific focus. And if you want to look at, I apologize for my pointer not getting over here. So when I was thinking about high priority programmatic priorities, if I had to make some recommendations, and this is where I am today, of looking at things that are high burden, persistent, pervasive inequity issues we have in the field of STD prevention that need urgent action for us to be able to reduce the burden and costs, that sort of, have got some urgent threats, and that we've actually got some tools to show that we can make an impact. Because next year when we have major cuts, which I think we're going to be having, if we don't have something to show an impact, we're not going to fare as well as we did this year, because this year we had to really show impact, and we're looking for impact that's a little more distal than just testing people, but not as distal as saying we're going to reduce chlamydia. So we're looking for some immediate outcomes that we can look at that are related to our targeted and scaled-up interventions. So in thinking about this, I came up with two sort of disease-focused and two population-focused areas of priorities that I think we're looking at the national level. Now, certainly states, have the flexibility to do whatever we want, but we've got a big problem with resistant gonorrhea that if we at the national levels don't start working on, we soon will have few drugs left to treat gonorrhea. Dr. Frieden does have a global congenital syphilis elimination winnable battle that I would think we should be recognizing that global does include the United States. And I think there's a lot of advantages for us focusing on congenital syphilis because it is something that we're already doing very well on. It's something that can link us into women's health issues with syphilis. And there's been a lot of discussion about what we've been doing with syphilis elimination for the last 10 years, where there's been a lot of good things, but also, at least based on our epi data, we're not really making a lot of progress. So if we could refocus some of our syphilis efforts into both a congenital syphilis focus and into more of a broader MSM, STD burden of infection, and not just be talking about MSM and syphilis, but be talking about STDs and the burden of STDs in men who have sex with men, and incorporating the sexual health focus that's happening at the center level. This will give us more flexibility to be broader in how we think about our approaches and the tools we use, where our focus is, our tools have been fairly narrow in our syphilis elimination efforts. And then if we really take a focus on adolescents, and one of the huge opportunities of looking at these two different populations is, for those of you who may not know, DASH is moving to the center. At least the STD, HIV, and pregnancy part, the chronic disease is staying over in chronic disease. So it gives us a nice link to our DASH partners. Our MSM focus gives us a nice link to, at least in many areas of the country, to our HIV partners. And our adolescent focus really is taking our IPP work and saying we want to continue that because our IPP work has been mainly focusing on adolescents and young adults. But it also allows us to include the HPV work that we've been doing here at the division. And even if we wanted to do some herpes work or some other areas, it gives us some flexibility both at the national level and for you at the state and local level as to how you want to prioritize your issues. Certainly what we need to be talking about once we get beyond these programmatic priorities that I would like to sort of finalize in the next few months, then we need to start talking about, well, what's behind these strategic priorities? And I think this is something where we at the national level need to figure out what our responsibilities are, and this is where we also need to allow state and local health departments, based on their needs, to figure out, what are their priority areas that they would want to fund with their federal dollars and their local dollars so that we can show some progress in programmatic impact in these four priority areas. And certainly we want to look at these areas from a health systems intervention standpoint and support. We also want to be looking at these from a policy, structural, and sort of environmental actions that we do. So these are sort of some overarching themes that we would look at when we start building out the program support areas. So that's an area that obviously we need further discussion that we're interested in hearing from you as well on. So with that, that is my thoughts and overview of the future of STD prevention after a few months being back here at CDC. And I think we're going to take this opportunity to answer questions that are coming in on the chat page.
Okay.
So I've got my team here sorting questions by topic.
Right. So would you like me to read the question?
It might be easier if you give it to me and I'll read the question.
Okay, we'll go ahead and do that.
It gives me time to think while I'm reading.
Here's one on strategies.
Okay, on strategies. So there's a question about what are CDC's plans to address more upstream factors that influence the prevalence of STIs in certain at-risk populations. So I can speak for the STD division. I have not asked this question of Dr. Frieden to know what CDC's plans are, although I will say that there is a structure within CDC that in most divisions there's an Office of Health Equity that reports to the Office of Health Equity and Social Determinants of Health at the center level. So I would say that we're very actively engaged at our center level of issues around health equity and social determinants of health. So first of all, I think all of us recognize that the issues that we're dealing with in STD are very similar to the issues that HIV is dealing with, that hepatitis is dealing with, and even that TB is dealing with. So one of the areas that we're working on is, first of all, I think we need to have better measures of social determinants of health. Pretty much what we have right now is just race, ethnicity is what we collect. So I've got kind of our surveillance and our social determinants of health team looking at better metrics that we can start implementing on our national surveys, such as the National Survey of Family Growth or NHANES, ways that we can look at in some of our surveillance activities, that we can do a better job of sort of measuring the health equity issues. I will say that one of the recommendations that came out of a consultation we had last week on prevention for health care is there is a general feeling from some fairly high up people, and these are like health officers that came to the meeting, that feels, and I do agree with this, that we in STD really need to start reframing what we do, and that we really need to start framing STDs as a health equity issue. All of you on this call, if you don't know, there's a national prevention strategy that was just released by the White House last week or the week before, and there's sort of 4 areas of focus, and one of them is health equity issues. The other good news is there's some priority areas. There's 7 priority areas, and sexual health and reproductive health is listed as a separate priority area, and there's some opportunities for us. So I think in addition to having better data to understand what's going on, I think we need to start developing integrated preventions, be it at the school level, be it at the housing level, be it at the employment level, that we work with our STD partners, our partners in HIV and other areas. I encourage people to look at these community transformation grants. Certainly there's a lot of focus on healthy communities, health equity in these grants, and I think if we can be the coattails and add on STD into some of these community level interventions is where I think we need to look at all of the activities that are going on in this area at CDC as opportunity. So I know there are probably some more specifics I could look at, but I do think that we need to be starting to look at these upstream factors as opposed to just sticking at the individual level and identifying infected individuals. So we'd love to talk more specifics about that with our partners at all levels, because I think we don't have a roadmap yet as to how we want to do that. Okay, another question is, very few state or local health departments have billing capacity. We need either funds or infrastructures to put this in place. Are there plans for discussions with HRSA, large insurers, to help find a way forward with billing? Yes, we at the national level, including myself, are meeting with our partners, and Raul Ramagera, in charge of our policy office, has already been discussing with the Bureau of Primary Care opportunities for us kind of selling our expertise and finding ways that we can help providers become kind of part of the network is one thing that we're looking at the national level, and having the medical home recognize that there's expertise out there that they need to link to or refer their patients to, because that's going to be a more cost-effective model than them trying to do that themselves. We're also working with NCSD and actually have given NCSD resources this year to be used over the next year to provide technical assistance with state and local health departments to develop billing capacity. There's a lot of expertise out there. Family planning has already done a lot in some areas with starting to bill. The amount of money that people are generating is quite substantial. There are some STD clinics that have been forced to start to bill and have developed some innovative models with sliding scales, not refusing care if someone can't pay. So we want to share some of those best practices as well. So yes, this is an area that we want to help state and local health departments, as well as we want to advocate at the national level so people understand the expertise that's out there and realize for the healthcare delivery system that it's cheaper for them to purchase that service than to try to necessarily in all places do it on their own, because we all know that a lot of primary care providers don't even know how to do a sexual history. So if you don't know how to do a sexual history, how are you going to identify someone who needs to be screened for STDs? We've got another question about if the division removes support for STD-MIS, how will it support development of alternative systems in state and local health departments? This is where, again, I think state and local health departments have to start realizing that CDC can't be your only friend and your only resource. You have to start taking care of yourselves and reaching out within your state health department to what's available to you. So if you don't know who your IT people are, if you don't know who your communicable disease epidemiologists are, if you don't know who your state epidemiologist is, now is the time to start making some new friends, because our resources, we did take some cuts this year, and I anticipate that we're going to be taking a number of cuts in the future years, because Dr. Frieden is not interested in, at least in the appropriations that are currently going to states. Those are going to be hopefully held harmless. So I do know that a number of states have gone to a NEDS-based system, and we are prioritizing us developing an STD case management model for that NEDS-based system. So that will be available to the states that have gone to some CDC, NEDS-based system. For states that are going on their own and using other systems, we need to have you start getting to the table. Certainly we like the Florida prison system, and we're encouraging people to look at that system. We're encouraging people to work with their HIV programs that have gone more electronic. Some have gone more electronic than others. And then lastly I can say is if you're coming to a stumbling block, that is when I am willing to come out and have a high-level meeting in your state to have the state health officer and the IT people meet with me and explain why STD is not at the table where all their other communicable diseases or other functions are. So we're going to help, and that's also the point of the new data management and surveillance system, data management and surveillance branch. Those staff will be the ones that will be available to do site visits, to provide technical assistance, and to help you move through this transition. This is not going to happen overnight. We're talking, this is at least a 5-year project, in my opinion. But if you don't know, Dr. Frieden has put us under an incident command structure. And when I arrived on the job, I was informed that I had to have all states receiving all electronic lab reports electronically within 3 months. Obviously, that hasn't happened, but we are having to report to the director on a monthly basis, I think, maybe quarterly, the percent of states that are receiving electronic lab reporting. And it's actually to our advantage because Dr. Frieden has taken the high-volume diseases, chlamydia, gonorrhea, hepatitis B, and HIV viral load is the metrics he wants to follow to make sure that those are being reported electronically to you. So we will be having further discussions on this because we recognize this is an area of huge need and an area where we're really challenged resources. Okay, there's a question, will there be a rescission of CSPS funds in 2011? There is a rescission of CSPS funds in 2011, if you haven't heard, across all programs, I think it's beyond CDC. And all of us are required to cut everything at this 0.2% level. I apologize for being a little slow in getting my letter back out to NCSD, but there will be a letter coming back to NCSD who inquired about this either today or tomorrow. And first of all, we're trying to minimize the bureaucratic headaches that you've got to do to modify your award based on this 0.2%. Unfortunately, PGO requires a budget justification to be revised. We're trying to keep it simple where you have to just revise your 424 and you just have to send us a one-page description of where you're making your reduction. You don't have to take it across all your CSPS, IPP, and civil elimination. You can take it wherever you want to see fit, whatever's the easiest thing for you to do where you feel like this cut should be taken. That rescission, though, and this is the way rescissions have been around for as long as I've been around for the last 22 years, that rescission will be applied to your base for next year. So when you're applying for your grant this year, your base appropriation will be permanently reduced by this 2% rescission. Someone's also interested in how the DHAP $11 million is being distributed. All of that money, none of it stays. All of that goes into the 60% CSPS pot. It all goes to state and local health departments. I think about 85% goes into the CSPS grant awards, and about 15% funds some of the DA staff out in the field. And the DA staff funded in the field are in the 12 cities that have high HIV morbidity. So we've chosen to support only DA in the DHAP high morbidity areas. We do have an extra $1 million this year so we've traditionally had $10 million every year from DHAP. We were given another $1 million this year that is specifically to focus on MSM and extragenital screening for chlamydia and gonorrhea, and looking at resistant gonorrhea in MSM. So those monies have gone out partly because of mechanisms. I've learned something at CDC. You may have money, but if you don't have a way to get it out, you can't get it out. So those monies have gone out to the sun surveillance sites to expand some resistant testing at the pharyngeal and rectal sites in their STD clinics. We may also be looking at getting some people back in for test of cures, and also possibly following people to look at HIV seroconversion so we can answer some of those questions are, how high risk is someone with rectal gonorrhea who's HIV negative today? What's their likelihood of becoming HIV infected within the next, couple months, which says something about rectal gonorrhea being at a minimum a risk marker for people at risk of future HIV. We've also given some money to the training centers to be working with HIV care providers to understand the barriers of why they're not screening at extragenital sites for chlamydia and gonorrhea. This should be covered by the healthcare delivery system. We shouldn't be paying for tests, but we hear there's a number of barriers. They don't know how to bill. They don't know what labs actually have these tests available. So that's where the additional millions going for this year, and we really want to start developing metrics to look at extragenital site infection and treatment. Someone's asking, what are the changes to the syphilis elimination funding in 2012? That's the second letter that you'll be getting this week from us, which is we're still waiting for an official ruling from PGO, which we've not gotten yet today as far as I know. Because of all the changes and cuts that we have seen at the state and local level, and because the formula that was created many years ago was created at a time that we didn't recognize that we would keep adding syphilis elimination sites based on the best thinking at the time, our formula has gotten way out of whack, and that we have a lot of base going to states with not too many cases, and we keep cutting the high morbidity states, especially in the South, with cut the level of 10% by this reformulation every year. As a result, I was concerned about this. I felt like we were going to be doing more harm this year if we reformulated again. Also, if you don't know, TB doesn't reformulate except for every 3 years. HIV is now going to a formula. They don't reformulate, every year. They do it every 3 years. I would like to have a discussion with NCSD and everyone about how we are distributing money. We don't want to do any harm, so we're not going to be making any major changes. But we were so concerned with the cuts in some programs that are heavily impacted by syphilis that we are proposing this year just to freeze syphilis elimination funding, not make any changes. Everybody just gets what they got last year. There might have been a few states that might have thought they might be getting something this year, but we're also having a discussion about the direction of syphilis elimination, possibly even considering putting syphilis elimination funds in the CSPS grant so you don't have to have a separate allocation, and that gives states much more flexibility of how they spend their syphilis money. Certainly that doesn't preclude states from continuing to do what they would be doing, but it gives us a little more flexibility. So we have to wait. PGO, and this is called freezing of funds. It looks like PGO, we've given a justification of the amount of harm that would be done by reformulating again this year and then maybe even changing it next year and not even having syphilis elimination funds. That I think the plan is we will be looking at freezing for next year, or through the freezing for the rest of this grant cycle, and then looking at how we want to proceed forward in 2013. Another question is, who in the division is leading conversations with the center and with chronic disease regarding opportunities for collaborating on interventions and monitoring the impact of the community transformation grants? and what are the plans for obtaining input in the field? Well, we are talking with the head of the Chronic Disease Center on what's happening with the community transformation grants. That's as high as I can go. I've had conversations. But we at CDC have been told that the community transformation grants are being run by the Chronic Disease Center, and we are not to be being involved, that they are in charge. So I would recommend that you work with NCSD and NASTAD and your chronic disease partners in your state to find out what is happening. Certainly, I'm willing to listen to input from the field on the challenges that you're having getting to the table with the community transformation grants, and I can let you know that we are doing everything we can here at CDC to have a holistic approach and have the community transformation colleagues see the importance of the health equity we have and the importance of reducing STDs when they're thinking about healthy communities and healthy environments. So another question is the research and evaluation dollars for extramural research. I was specifically talking about dollars that go out to support research in the field, be it through multi-site studies, be it through to a university to do research. And we really have a lot of our research has been funded with end-of-the-year money, and then it kind of has disappeared. I've had a hard time kind of tracking things over time, but I'm one that doesn't worry about the past. I'm trying to move forward. So we really have one extramural grant that was released before I came on looking at the role of chlamydia and infertility, because it is an estimate that's important for cost models. But I am looking at creative ways that we can start having some more extramural research out there, either among programs or among universities, because if we don't build our research and evaluation base, we're not going to be having the data to justify our programs. So this is going to, obviously be something that's going to be something we're going to have to be creative about in looking at future funding and existing funding, and as money becomes available, either through projects ending or through vacancy positions, we might have to look at how we can reshape our pie chart. There was another question about research and evaluation budgets, about $700,000. Will drug companies be doing research? Okay, we are doing, this is a question about will drug companies be doing research on new antibiotic therapies for GC resistance. We do have some challenges in our country where our pharmaceutical industry is profit-driven. And we have not seen an interest in any drug development in the area of GC, despite a lot of advocacy by CDC and outside partners. So in the meantime, we are working with NIH. The good news is our director, Dr. Frieden, is very concerned about the profit-making approaches, including in the vaccine era. It seems that when CDC recommends, because the data suggests that you don't need 3 shots of a vaccine, you only need 2, what happens is all of a sudden the cost of that vaccine seems to go up for 2 doses than 3 doses. So we're very concerned about our prevention strategies and interest in the pharmaceutical area, but there's 2 things. We currently are funding an NIH trial looking at 2 currently available drugs, gentamicin along with azithro and gimifloxacin, using the NIH Clinical Trials Network. We should have results by the end of, or by the mid-2012, but we're concerned that we need other options. If you don't know, during the anthrax era, there was a lot of concern that we would potentially have some emerging infections with no drugs to treat them. So there was a huge drug development and stockpiling of some very interesting drugs that Dr. Deal at NIH thinks might have some potential for GC. So we're going to be looking at possibly getting into the bioterrorism stockpile and seeing if there's some drugs there we can start studying. So I will say we at CDC are working very closely with NIH on drug development, and we're also going to be working with the venture capital arm of NIH that Obama has developed for drug and vaccine development when there's not an interest in the pharmaceutical area. I will say, though, that we are trying to generate funding that if there's not interest in drug development, at least there can be interest in funding clinical trials. So we are trying to be creative to get some resources for funding this area that we think is critical. So we discussed role. Another question was on CDC's role in the development of antibiotics. Another question is, how are we going to link STD prevention with teen pregnancy prevention when funding is currently not linked? I think right now there's a lot of challenges with linked funding and people worrying that good things that are being funded with siloed funding won't happen if we start linking funding. If you don't know, we have an experiment in progress right now where the center is allowing STD programs, if they want, to take 5% of their funds and let it be used for either HIV or for hepatitis or TB. HIV can do the same, so can TB and hepatitis. Also at the center level, the center can withhold some funding of our grants if they want to start using it for something else that they think is higher priority. We don't have that same link with the teen pregnancy prevention program, but I've already met with the new director of their division, Dr. Wanda Barfield, and they're very interested in working very closely with us. So I think this is an example where we may not necessarily need to have funding link, but we can link our expertise and achieve the same goals at the client level. So again, like I've encouraged local staff to start knowing who their IT people are, I think it's important for you to find out who is getting pregnancy prevention funding at your state. We know some states are cutting those funds, and trying to offer your expertise and see if you can integrate STD prevention into those existing programs and make them more holistic and more comprehensive. Okay, we don't have enough time to answer all questions. There was one person that had a question about the rationale for separating epidemiology and statistics and surveillance and data management. One of the rationales is that I had two very large branches and then a lot of sort of medium branches. A lot of statistical people need to work with EPI, but also data management needs to work with EPI. And if you don't know, also in our health services research branch, we have a lot of health economists that do a lot of modeling. So what I tried to do was to have the three different areas of expertise that have to work across disciplines and across branches kind of divided up. We sort of had the stat and data management in one branch, and then we had the health modelers in another. So I thought it was better for overall kind of collaboration and working across branches to have the EPI and STAT because they worked mostly together. The data managers were mainly working with surveillance. The health modelers mainly work on health services research, but they also need to work with the EPI and the STATs. That was sort of the reason for those three branches being configured the way they were. So there's a question, and probably this is a good one to conclude with, and I think what we'll do is I'll try, like we've done for our other webinars, to put a frequently asked question and answer up on our website. Do we want the public reading these questions and answers?
Well, it's recorded as well. The call is being
recorded. Okay, so we'll figure out how we're going to get this up on our website so that the questions that I've answered so far are available, and then we can also address all these other questions that have occurred. If people feel that it would be helpful, because I realize there's a lot happening, and it's hard. I'm going to start getting out and about and doing site visits to programs so that I can learn more of all the good work that's happening locally and the challenges that I know everyone is facing. But if it is helpful, we could schedule another hour webinar, in the next month, probably after ISTDR, maybe towards the end of July or the beginning of August, and I can also just answer more questions. I mean, if that would be of value to people. So let us know by emailing us. Who should we email? Yeah, so email your consultant if you want to either have more questions that you had time to think about this and or you review the taped webinar, Send more questions in. This is an iterative process. I am a person that thinks out loud a lot. A lot of times people think when I'm saying something, I've made a decision. That isn't the case. When I tell you I've made a decision, then I can tell you I've made a decision. So this is an evolving issue. I think, STD prevention is at a crossroads. I think we've got a lot of good things that we're doing, but we also need to be thinking about where we're headed and how we can be fit for purpose in this sort of healthcare changing environment. So with that, we will get these other questions up on our website, and if there's interest, I'm happy to have another opportunity to hear from you indirectly through a webinar. So I thank everybody for their time today, and I thank you for all the work that you're doing on a day-to-day basis for STD prevention in the United States.